Hello, my name is Daniel Rodriguez. Today we're going to talk about immunotherapy in renal cell carcinoma. The definition: the renal cell carcinoma is the third type of urologic cancer and has a poor prognosis with 30% of metastatic patients at diagnosis. The antigenetics and targeted immunotherapies led to treatment remodeling, emphasizing the role of the tumor microenvironment. However, long-term responses are rare with a high rate of resistance.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread. For more
Now we're going to talk about the applications in medicine. The treatment and management of metastatic renal cell carcinoma have radically changed over the past 20 years. Initially, the first generation immunotherapy with cytokines, interleukins, or interferon represented the standard approaches but with poor results. The development of tyrosine kinase inhibitors, mainly vascular endothelial growth factor receptor inhibitors, largely improved the prognosis of both progression of free survival and overall survival.
I think the most interesting data and the one that people are very excited about is the Emotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. So let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors, so these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So in this phase 3 trial, though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is 2 co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population there was about 40% of them, as well as an intent-to-treat population. And what they found was the PFS, for instance, for the combined therapy is in the order of 11.2 months, compared to only about 7 months for the sunitinib arm. So these are compelling data. And in terms of toxicity, actually there's not a whole lot that it's unexpected, if you will. So I think it's a fairly tolerable regimen. So I think moving forward, this is a great candidate. Perhaps, we will be seeing more this year. I think it's rapidly evolving. And the trial I just mentioned, the Emotion trial, is but one of them. Last year at ESMO, we heard about the Checkmate 214 trial, which looked at the combination of nivolumab and ipilimumab versus, again, sunitinib, and that was also a positive trial. So we are starting to see now these combination IO drugs that are pretty soon going to be changing the landscape of treatment, because right now IO therapy has largely been second-line therapy with nivolumab. So I think we are starting to see these agents move up, and not just maybe single agents, but in combination.
Next, we're going to talk about the pros and cons. The emergence of immune checkpoint inhibitors, alone or in combination with anti-cytotoxic T lymphocyte antigen 4 and anti-PRAM-DED1, showed interesting results. Targeted immunotherapy is an alternative to antigenetics because clear cell renal cell carcinoma is also considered an immunogenic tumor with high numbers of immune cells such as tumor-infiltrating lymphocytes. Recent trials propose antigenic in association with targeted immunotherapy to overcome resistance, emphasizing the role of the tumor microenvironment. And this strategy is currently an option in the first-line treatment.
Clear cell renal cell carcinoma is the most common malignant tumor of the kidney in adults. It is also sometimes called conventional or classic type of the renal cell carcinoma or Gravit's tumor, but those are historical names and they shouldn't be used anymore, so clear cell renal cell carcinoma is preferred name. Most of the cases of renal cell carcinoma is associated with VHL gene mutations. VHL is an abbreviation which stands for von Hippel-Lindau disease. Carcinoma typically consists of clear malignant tumor cells arranged in the solid alveolar or acinar pattern. So on higher magnification we can see these cells with voluminous clear cytoplasm with quite round or slightly irregular nuclei. These clear cells are arranged into small solid nests, which are encircled by the small capillaries. So this is the capillary with endothelial cells and erythrocytes inside of the lumen. Here we have the malignant cells, small nests. These nests can sometimes resemble alveolar-like structures. So, for example, here we can see something that looks like a lumen. Therefore, it is also described as alveolar or acinar pattern. The tumor should be graded based on the nucleolar appearance, and we have so-called isograding system. So grade 1 tumor is the tumor associated with inconspicuous nucleoli or absent nucleoli. So with most of these nuclei don't have a prominent nucleoli, that can be called grade 1. Here we have the example of these cells. They should be assigned to the grade 2 subgrade. If we have really prominent nucleoli, which can be appreciated in low magnification, that is grade 3, and extreme nuclear pleomorphism associated with multinucleated giant cells or sarcomatoid appearance or rhabdoid change of the tumor, that should be called a grade 4 subgrade of the renal cell carcinoma. Renal cell carcinoma is typically associated with vascular type of metastasis, which is kind of unusual because most of the carcinomas go into the lymph nodes. So this is one of a few exceptions, together with choriocarcinoma or papillary carcinoma of the thyroid gland, and renal cell carcinoma very commonly can metastasize into the renal vein. If the tumor is small, well circumscribed, and limited to the renal parenchyma, then it has quite good prognosis after resection.
Now the issue applied to Ecuador. In Ecuador, white bone is 17 over 1,000 in men and 0.76 over 1,000 in women. Suffer from renal cell carcinoma, 100,000 in women. Suffer from renal cell carcinoma in an estimate of 1.17 of every 100,000 men and 1 of every 100,000 women. And for the conclusion, the renal cell carcinoma include distinct entities in specific molecular alterations. Among them, the renal cell carcinoma, the most frequent, is particularly characterized by its angiogenic and immunogenic tumor microenvironment, with complex interactions between stromal and immune cells. Like tumor cells, intratumor heterogeneity is present in the tumor microenvironment with a variable distribution and phenotype, and consequently favors the resistance to treatment. Thanks.